Okay, we're now live. Hi, this is Elliot Fisherman, and welcome to Thursday, August 10th. This is Facebook Live. Hope everybody's doing well. A lot of people are away. We're very busy. I'm sure you're very busy as well. I guess everyone's going away. It's the last hurrah for the summer. Also, some people are taking their kids to college or some places around the country. I know even high schools started mid-August, elementary schools. So it's getting to the last half of August. And in the old days, remember, we all would worry about the start of school after Labor Day, that Tuesday. But now everything has been shifted back anywhere between 3 and 5 weeks. So kind of strange. Under strange things, I read this morning that Kim Kardashian, not that I follow her, was doing an Instagram endorsement for whole body MR. She was giving her, it was one of those Instagram pictures, but she was giving her take on why you should be doing it. So in case you're a big Kim Kardashian fan that you wonder what she's doing, why maybe you didn't see her yesterday, she was probably getting a whole body MR. So whatever. Hope her scan was normal. That's all I could say. Anyway, today, let me say hi to John Biacchino, who's not with Kim Kardashian. I don't want to confuse that. John's home today. John's one of our senior techs. I'm working this weekend, John. Hopefully, I think I'm going to see you this weekend. And I have to work Saturday and Sunday. Ugh, but my turn. This talk is going to be on lymphoma of the GI tract, in part that I had a bunch of cases recently of lymphoma of the small bowel and colon. And, we talk about lymphoma. We all do a lot of CT scans for lymphoma. Typically, we're looking at adenopathy in the chest, mediastinal adenopathy, maybe lung involvement. The abdomen, maybe big spleen, splenic lesions, sometimes liver lesions, looking at adenopathy, the extent of disease, follow-ups, looking at PET CTs. So all things we all do in practice, but lymphoma of the GI tract, and I'm going to look at 3 things: stomach, small bowel, and colon. And I showed a bunch of cases yesterday. I do on Wednesday. Yesterday was Wednesday, case conference, and so I quiz people on that, showing them the spectrum of lymphoma. I'm also, if all is well, finishing up a talk on lymphoma today, and then Sarah will check it, and then I'll record it tomorrow. And if all's well, I think you'll see it in about 6 or 7 weeks as we go through our cycle. End of October probably is when it's going to be. So let me just go through some of the thought processes and talking about lymphoma. Now, if we speak about the stomach first, classically in CT in the early days, people would differentiate adenocarcinoma from lymphoma by saying wall thickness over 5 centimeters was lymphoma. Lymphoma also had bulkier nodes. Lymphoma adenopathy also went beneath the hilum of the kidney, and gastric cancer stopped by the hilum. Gastric cancer was also more likely to give carcinomatosis. Lymphoma is not. Well, we do see in our practice that, yes, I have a great case Sheila Schetz showed me of really bulky lymphoma, wall thickness 10 centimeters. Most of the cases we do see are wall thickening in the 2 to 3 centimeter range, so it looks very much like adenocarcinoma. Hard to distinguish it, which is why you get a biopsy before you treat or go to surgery. Lymphoma can have ulcerations. Again, if I saw bulky nodes, it would be easier, but often the nodes are small and I'm simply seeing the mass in the stomach. Bringing back the point about good gastric distension. I mentioned yesterday at a conference that I've seen a bunch of GI lymphoma cases over the last 2 or 3 months from the ER setting, patients presenting with vague abdominal pain or mild weight loss or just dyspepsia. So it is something in your differential, things you need to be thinking about when you're reading scans. Then we talk about lymphoma. Lymphoma can be polypoid lesions, can be infiltrating and very bulky lesions. People spoke about aneurysmal dilatation in the days of fluoro, Bronwyn Jones days, for example. The cases I saw recently were bulky masses, very positive on PET, but real wall thickening with infiltration into the mesentery. We can get lymphoma with more focal bowel involvement and then the bulky mesenteric disease, so-called sandwich sign. But these were cases with bulky tumor. Now, one of the things we distinguish in the differential is lymphoma can be bulky, usually displaces, doesn't obstruct, But the same could be true with GIST tumor. They can be bulky, but usually they're more eccentric. Adenocarcinoma can be infiltrating, never quite as bulky, and when it gets pretty large will obstruct. So that would be helpful. Lymphoma, like many things, can cause intussusceptions, particularly when the masses are small and they're polypoid. So there's a range of appearances from lymphoma. Lymphoma can be focal with a bulky mass or multifocal with multiple masses present. I then showed some cases of large bowel involvement, a tumor in the cecum wall thickening, looking very much like an adenocarcinoma, which is more frequent. You see a bulkier tumor where there's cecal involvement, but also ileal involvement. Colon cancer does not typically cause the ileocecal valve. Lymphoma does. So if I see infiltration and I see bowel involvement of the small bowel as well as of the cecum and it's bulky, I'm then going to be thinking about lymphoma. I have a couple cases I showed where there was some adenopathy local. I didn't show any cases of really bulky adenopathy, but that can occur as well. Lymphoma can be multifocal. That's true in small bowel, stomach, and colon. And in the multifocal, it can be very bulky, but again, whether it's small bowel, stomach, or colon, lymphoma, even when it's large, has this propensity not to obstruct, where other tumors will, lymphoma will not. Again, when I look at lymphoma, I look really carefully at the other organs a second time. Make sure you're not missing a splenic lesion. Make sure you're not missing hepatic lesion. Make sure you're not missing renal lesions. All of those can occur. And remember, with lymphoma, multi-organ involvement is very, very common. So just picking up one mass doesn't mean you're not missing a couple others. Again, things I'll look at is the mesentery, looking for mesenteric infiltration, periodic nodes, mesenteric nodes, and the like. You can see bulky lesions also in the rectum. It can look very much like a sarcoma at times. Lymphoma, the cases I mentioned yesterday we had were patients with no risk factors. Some risk factors for lymphoma: sprue, patients who are immunosuppressed, HIV patients, AIDS patients, patients on certain chemotherapies are more likely to get B-cell lymphoma, and those are the patients where B-cell lymphoma can be anywhere from the heart to the lungs to the liver, spleen, kidneys, colon, small bowel, stomach. So again, multifocal disease is usually the hallmark of lymphoma, but it doesn't need to be. And many of the cases I showed yesterday, and I'll show you in conference, really it's the size that pushes you to lymphoma when they're big. And when they're small, and unless there's significant nodes, it's just hard to get past adenocarcinoma. So those are some helpful hints. I'll give you the lecture. What I'll do is, I think Lily knows best, but next week I think is the third Thursday of the month, and then I do the quiz. And maybe what I'll do on the quiz is I'll show you only GI lymphoma cases, maybe almost only GI lymphoma cases, so you can get a feel of how the cases look before I give the lecture. So with that, I hope everyone has a great weekend. I hope the weather is pleasant. I hope you're not having hail and thunderstorms and fire and brimstone and everything else. I saw the sadness in Hawaii, in Maui. Hawaii is always damp, wet. You always think about no forest fires. Massive fires in Maui. I just can't imagine. I saw some of the pictures. It's very sad. I hope everybody all our friends from CTisus who live in Hawaii, specifically Maui, are safe and sound. And with that, I wish everybody a great day.